today. I'm going to just time myself because I'm told people are very strict. So I'm going to give myself 13 minutes and then I'll conclude. So I'm going to start now. Okay, thanks. So I'm going to start with a statement that we have from the South African Medical Research Council that talks about we were established during apartheid, and we acknowledge the issues of apartheid and colonization and the lack of equity in our country. And as this MRC, we're committed to moving forward and ensuring that we address the health inequities of our country through research. Can I have the next slide? So I'm going to talk about the role HIV and COVID played, and I'm going to talk about a few lessons. And I think the first lesson that we learned in the COVID pandemic was the importance of vital statistics, the importance of generating local evidence, and the importance of building vaccine R&D capability. Can I have the next slide? So first of all, I'm not going to talk about our fragile and strained public health system or our overdependence on the global north for pharmaceutical products, but I'm going to talk about the lack of research facilities and clinical trial capability and the lack of investment in COVID-19 vaccines and other vaccines on our continent. Can I have the next slide? The first thing I'm going to say is that research infrastructure is paramount for responding to epidemics, particularly in Africa. Can I have the next slide? Yeah, we see in a publication from 2020 that less than 10% of global clinical trials happen in sub-Saharan Africa. Next slide. And that the countries that are most likely to be involved in clinical trials are Uganda, South Africa, Kenya, and Malawi. And you can see that during COVID pandemic, the amount of global trials we did in Africa plummeted. Can I have the next slide? There are lots of challenges that comes to running trials in Africa, everything from our regulatory authorities, issues around capacity development, the quality of our data, issues around clinical trial insurance, and our study population health status. Can I have the next slide? But I want to make the point that clinical trials are very important to be conducted in Africa, and we need to conduct these studies to evaluate safety and efficacy, as well as understanding the mechanisms and correlates of protection. And because we have a high burden of infectious disease, it's important for us to do clinical trials. Given our genetic diversity, we also know that this may impact on safety and tolerability, and therefore we need to make sure we are represented in global trials, and also in addressing the issues of pregnant women, infants, and children, who are often the last people to be studied in terms of safety. Can I have the next slide? So the next lesson that we learn in Africa is the importance of vital statistics and surveillance. Can I have the next slide? Africa was a black box when it came to understanding the true burden of the COVID pandemic in Africa. So we have no idea what the excess death rate was in Africa, besides South Africa, that had one of the highest case fatality rates at a global level. Can I have the next slide? Yeah, you can see that despite having a young population, South Africa has a high excess deaths per 100,000 population if you compare us to Brazil, the UK, and the USA during COVID-19 pandemic. So we had a very bad pandemic, and it's hard to understand what the true impact of the COVID pandemic was in the rest of Africa. Can I have the next slide? Also, I'm sure you've seen this slide. Importance, we just had a recent HIV prevalence survey done in South Africa. 12.7% of our population are HIV infected, and which is around 7.4 million people who are living with HIV in South Africa, showing the need for urgent biomedical interventions. Can I have the next slide? So lesson 3 is the importance that HIV played in building the infrastructure in Africa. Next slide. So if you see the next slide, you can see this is the HPTN and HVTN clinical trial sites in Africa. And these trial sites have been critical in responding to the COVID pandemic. And if it wasn't for these sites, we wouldn't have been able to rapidly roll out COVID vaccines in the latter part of the pandemic. Next slide. Now you can see the clinical trial infrastructure investment in Africa. You can see South Africa as compared to non-South Africa. You can see around 38,000 individuals have been involved in everything from phase 1 to phase 3 trials, as well as observational studies. But But unfortunately, you can still see that South Africa enrolls most of these participants at an African continent level, showing the need to improve the infrastructure outside South Africa. Next slide, thanks. And this just shows you that very few COVID-19 vaccines were evaluated for efficacy in South Africa or in Africa. And yeah, you can the mRNA Pfizer one, the other one was the ChAdOx one, and the third one was the A26 one. Only Kenya was involved in the ChAdOx together with South Africa. Next slide. We also have very few countries in Africa that contributed to evaluating real-world effectiveness. And the biggest study to evaluate real-world effectiveness was the Sisonke study conducted in South Africa in around 500,000 healthcare workers. Can I have the next slide? And this just shows you the data coming out of our publication establishing the efficacy, the real-world efficacy of our single-dose Ad26 vaccine, and showing the fact that we were able to replicate what was happening in the efficacy studies. Can I have the next slide? We also show that we were able to look at the efficacy of the Pfizer vaccine during the Omicron wave in South Africa, and we were able to, at a global level, show the fall-off of efficacy during Omicron, but also were one of the first people to publish real-world effectiveness around Omicron and the role of the mRNA vaccine in efficacy. Next slide. And again, we were able to show, compare both the both the Ad26 and the mRNA vaccine. We were able to demonstrate the efficacy during Omicron, showing that these vaccines, although they were effective, there was a loss of efficacy over time. Can we have the next slide? Just looking at some of our data coming out of the Sisonke study, which was that healthcare worker study that enrolled 500,000 healthcare workers, we show the value of boosting. And this slide shows you that hospitalizations declining just with a boost, and it didn't matter what you boosted with, but after boosting, we had a decline in hospitalizations. And next slide. And also a decline in deaths. So very few deaths happened after the boost. So the important take-home message from the Sisonke study is that any vaccine, doesn't matter whether it was an Ad26 or an mRNA vaccine, just having a second vaccine helped with preventing deaths and hospitalization. Can we have the next slide? So that's the sadness about Africa. Although there was a lot of vaccines rolled out in Africa, we had a real opportunity to compare real-world effectiveness across all the vaccine platforms. And it's unfortunate that as a continent, we weren't able to look at all the vaccines and the real-world effectiveness that occurred on our continent. Next slide. So the fourth lesson is the importance of generating evidence of the impact of HIV on COVID-19. Can I have the next slide? And this just shows you that, the role that HIV played in COVID mortality. If you were a person living with HIV that had a low CD4 count or was viremic, you can see that you had a double risk of dying from from COVID as compared to people who were aviremic or had good CD4 counts or were HIV negative. We were also, next slide, sorry, can I have the next slide? We were also in our Sisonke study able to evaluate the role of HIV in impacting on effectiveness. And this slide just shows you that if you were HIV infected and you got COVID, the vaccine effectiveness was less effective against death as compared to people with other comorbidities. Next slide. I'm going to show you just quickly some of the issues around immunogenicity and HIV infections in people living with HIV. This was a study we did in South Africa, where we compared full dose and half dose J&J and Pfizer to see whether we could use fractionated doses. And we compared this in HIV negative and people living with HIV. Can I have the next slide? So this slide looks at the spike binding antibody titers in both people living with HIV and HIV uninfected individuals, and shows you that by the time you reach week 24, it doesn't matter whether you were HIV negative, whether you were viremic or aviremic, you had we were able to boost binding antibody responses, and there was no difference at the end, showing the value of vaccination again. Next slide. Looking at the neutralizing antibodies again, we also saw that boosting rescues the neutralizing antibody response in viremic and HIV uninfected and aviremic individuals, regardless of the booster platform. So again, therefore, just showing that it doesn't matter which vaccine you got, at the end, these vaccines increase neutralizing antibodies and binding antibodies. Can I have the next slide? Lesson 5 is that Africa is critical to the evaluation of HIV vaccines. Can I have the slide? So this, South Africa and Africa have been the forerunners of evaluating HIV vaccine efficacy studies at a global level. We've been involved in HV10 705, 702, the PrEP vaccine that you heard about yesterday, and the HV10 703 study, which is the study of neutralizing antibodies. And these are critical studies because they basically tell us whether these vaccines are going to work and try and establish correlates of protection. Can I have the next slide? What they have shown, despite the active vaccinations not being effective, what they keep on showing is the high level of HIV incidence on our continent, and in particular in South Africa, showing the need to invest in biomedical interventions. Can I have the next slide? But also what's important is that these studies help us understand the correlates of protection. And what we see with both 702 and 705 is the role for the V1, V2 IgG or the V1, V2 IgG3 in partially protecting against HIV in our studies. Can I have the next slide? Yeah, you see from HV10 702, which was a derivation from the RV144 study that showed partial protection, showing that if you have a good CD4 response measured in magnitude and polyfunctionality, together with high levels of IgG2 V1, V2, you can see that there is a level of protection, showing that we do need to concentrate much more on the V1, V2 area of the HIV. Can I have the next slide? And then in 705, another indication that there's a possible trend to V1, V2 being a correlate of protection in our correlate study in 705. So showing again the importance of the work that we do despite the lack of efficacy in our vaccines. Can I have the next slide? And then just going to the AMP study, this was a study looking at a neutralizing antibody called the VRC01. This antibody is targeted against the CD4 binding site, and this study was conducted both in Africa and in the Americas. Can we have the next slide? The important thing about this showed the protective efficacy of the single dose, the single monoclonal antibody as an infusion, and compared low dose to intermediate dose to placebo, and showed that if the virus was sensitive to the VRC01, there was a protection. Oops. Stop. There was a protection there was protective efficacy. Can we have the next slide? The importance of this study, next slide. The importance of the study is that it sets a correlate to protection with PT80, next slide, and showed that it's important that this correlate will be important for the future. Can I have the next slide? Important that we need to galvanize efforts to fast-track vaccine R&D in Africa. Next slide. Next slide. Just showing you that very few candidates for COVID vaccines came from Africa. Next slide. And that we need to do more than fill and finish and labeling in Africa. We need to do working with vaccine R&D, because a lot of our population come and we only produce 1% of our vaccines. Can I have the next slide? I know, I've got one more minute. This just shows you we established an mRNA transfer hub in Africa, in South Africa. Next slide. Just keep moving. Keep moving. I want to just get to the last one. So we need to become a leader in African. Sorry, slow down. We need to become a leader in HIV vaccine discovery. There's a couple of work we're doing in both neutralizing antibodies and active vaccination and neutralizing antibodies. This is in HIV exposed uninfected infants. Next slide. Neutralizing antibodies in looking at passive infusion of neutralizing antibodies in infants to prevent breast milk transmission. Next slide. And then just to talk about the brilliant consortium that's just been awarded to a group of us in Africa to make vaccines and to discover vaccines in Africa. Next slide. Run by, it's to harness and catalyze African scientists to contribute to an African-led effective vaccine. Next slide. 8 countries run mostly by women. Next slide. These are the people that are involved all over Africa, from Nigeria to Zimbabwe, Zambia, Uganda, Kenya, and Tanzania. Next slide. And just to make sure that we're going to do vaccine discovery, preclinical development, and vaccine clinical trials. Next slide. And then just our candidates that we'll be working with, CAP 255 and 256. Next slide. And just to finish that, surveillance is important. We are critical for an HIV vaccine, both in sexual and PMTCT conditions, and that we must invest in vaccine R&D. I just want to just acknowledge people, if you just run through the acknowledgements. Can you have the next slide? My funders, next slide. The HVTN, next slide. The Stonky study team with Linda Gale Becker in the audience, next slide. And then the brilliant consortium. Thank you very much.
So our next speaker will be Madam Johannah Joy. Just Joy. All right. Joy is a former Minister of Health in Botswana, and she's currently serving as the Executive Secretary of the African Leaders Malaria Alliance. She also co-chairs the Global Partnership and Fund to End Violence Against Children, as well as co-chair the Lancet Pathfinder Commission on Climate Change and Health. She is also a board chair of the Rollback Malaria Partnership to End Malaria. I was just going to go ahead to your topic, that you will be speaking to us on the topic titled Pandemic Preparedness Framework, Implication for Africa. Please welcome Joy. Thank you.
Thank you, Madam Chair. I hope I will be alert enough to give you a brief expose. But President of ICASA and your committee, honorable ministers, distinguished members of civil society, distinguished ladies and gentlemen, you would have thought that in the wake of the cataclysmic COVID-19 pandemic that has just been described by our expert here, the world would have rushed to break the cycle of panic and neglect, and appreciate that we need decisive measures to guard against the devastation of a future pandemic. Any intelligent person would have thought this. We have learned lessons from COVID-19. Many of these lessons were relearning because of truths that were made evident decades ago by the HIV/AIDS pandemic, or even more recently, the West Africa Ebola outbreak. We know that the best progress comes from the partnership between science and government and community activism, that it is this collaboration and this cohesion that guarantees equity and protects human rights as the central features of good pandemic preparedness and response. We know this. We also know that the quality of pandemic response is measured by the extent to which it reaches the most vulnerable and the most marginalized communities. Global Preparedness Monitoring Board, which I have the honor of co-chairing with former President Kolinda Grava-Gitarovic, released the 2023 report just over a month ago on the state of the world's preparedness. We found that decisive measures to ensure we have learned these lessons for good are still hanging in the balance. Global preparedness is fragile at best. Can we go? Yeah, let's go to that next slide. The pandemic is seriously underfunded and therefore resources, the pandemic fund that is seriously underfunded, and therefore resources are not available at all for countries based on need. In addition, surge financing is not available in most of our countries. So when the next pandemic hits, we'll still be unready. We still do not have mechanisms that guarantee that medical countermeasures, vaccines, diagnostics, therapies, technologies are accessible to all people across communities, countries, and regions, and a legally binding instrument that recognizes the mutual obligations of all countries and all sectors, private, animal, human, to create and maintain a web of effective pandemic preparedness and response is still being negotiated, even now. Yet again, the voices of communities, of women, of youth, of civil society, particularly in the global south, of people with disabilities, the indigenous peoples, are not being recognized. Surely we had learned this lesson before with HIV/AIDS, but it appears not. Our findings are based on a comprehensive monitoring framework developed by the board and applied for the first time this year. We drew on the advice of dozens of experts from across the globe, from all the regions, and from different disciplines to assess and rate the state of preparedness in 3 critical areas. First, equity. Second, leadership and accountability. And third, the coherence of the global system. So this is the heat map that you can see on the screen. These ratings show that there are many gaps, and you'll see that the heat map hasn't got a single green on it. There's not a single dimension of preparedness where we felt we could say with confidence that the criteria for success has been fully met. 4 key measures that must be part of the global treaty to be negotiated in Geneva in May are vital to repairing the fragility of global preparedness. 1 is strengthening independent monitoring. 2, making fundamental reforms to financing. 3, boosting R&D, technology transfer, local manufacturing where it is most lacking. And 4, engaging broader partnerships, working with communities, with civil society, uniting the leadership, building cohesion between sectors. Following the One Health model, you in the global AIDS community have demonstrated the importance of target setting and accountability. For more than 20 years, the scale up and effectiveness of HIV/AIDS treatment has been supported by globally endorsed targets, whether it is 3x5, 90-90-90 targets, 95-95-95 targets. I do not need to convince you in ICASA that these targets have been a key instrument of accountability, enabling the objective measurement of country progress and helping to focus efforts where they are most needed. But I do need you to shout from the rooftops that this lesson must be applied to pandemic preparedness. It needs to be monitored. There need to be accountability tools. People living with HIV are particularly vulnerable in pandemics. This too is our fight together. Our first recommendation, next slide please. I'll be very brief. Our first recommendation, next slide, is monitoring and accountability. And I've just referred to it now. They need to link every level of preparedness from community to national to regional to global levels, combining self-assessment, peer reviews, and independent expert monitoring in order to ensure that we are all ready as a global community. Our second recommendation is financing. The gaps in pandemic financing remain huge. The new pandemic fund goes only part of the way to fill in them. The fund concentrated its first round on strengthening disease surveillance and early warning, laboratory systems, and workforce capacity. But even then, it was only in a handful of countries, without addressing the full gap in any one country, even of this area alone. So there is a huge need here for increased resources to build capacity, particularly in our region, in Africa, for manufacturing of medical countermeasures, for R&D, for ensuring that there is surveillance, genomic surveillance capacity in every single country, one health approach in every single country. Surge financing capacities are built. Channels need to include innovative public-private financing mechanisms, better use of IMF special drawing rights, other measures such as debt swaps facilitated by international financial institutions. More fundamental changes at country and regional levels are needed to free up the fiscal space for countries to make greater investments from their own budgets. Why are we spending so much on the military? Maybe because I'm not a military person, I don't know. Our third recommendation as a board is to reinforce research and development, and I would not say anything about it because our expert spoke about it here. The new public health order on the African continent, championed by the African Union and the Africa CDC, is bringing together renewed coherence to the continent's agenda for self-reliance in health. We must all participate in this. We must ensure that Africa builds its own capacity, its own expertise, and is able to meet the next pandemic head-on with its own science and its own medical countermeasures. The final recommendation by the Global Preparedness Monitoring Board is that there is a new approach to multi-sectoral, multi-stakeholder engagement. The world of pandemics and health emergency in general can learn a great deal from the HIV/AIDS community. It seems that public health authorities have to learn over and over again the same lesson, particularly our leaders. Rights-based approaches still do not seem to come naturally to our policymakers, to our political leaders, limiting the ability of physicians, epidemiologists, laboratory technicians, and directors, health workers, even when they know the evidence shows that putting rights at the center is what makes their work effective in the real world. The trust deficit between countries, but also within countries, undermines our collective commitment to preparedness and progress. So we must build and rebuild this trust. The African Infodemic Response Alliance, which WHO, including our regional office in Africa and partners, launched in December 2020, is just one example. But we need Africa-friendly solutions, African solutions to the challenges that we have, particularly when it comes to opposition to medical countermeasures. Global preparedness is fragile, but it is not irredeemably fractured. We have it within our power, the means to repair the preparedness for good from the lessons that we have learned. And we have on this continent the will and the resolve to drive it forward. So let us join hands. Let us make pandemic preparedness a reality, in as much as we are making winning the war against HIV/AIDS a reality on the continent. I thank you.
Thank you, Joy. That was brilliant. And also thank you for giving us 2 minutes. It's indeed my pleasure now to please welcome Mr. Richard Lusimbo, who is a founder and director general of the Uganda Key Population Consortium, which is a coalition of key population organizations and networks that brings together representatives of key populations to collectively define and advocate for issues of common concern, including responding to the shrinking civic space and resources for key population-led programs in Uganda. Richard is passionate for the marginalized community voices to be represented in policy, laws, national frameworks, as well as working groups and committees, and spaces where the human rights and health issues are discussed and documented. Richard will be speaking to us this morning about community-led data-driven response, what works and what doesn't, the case of key and vulnerable population during the COVID-19. Let's welcome Richard. Thank you.
Good morning. Good morning.
Good morning.
Thank you. Thanks so much for having communities. And I also want to take this opportunity to appreciate our experts, but also our leaders. And I'm so delighted that we get to speak about pandemics, but also we get to bring the voices of communities at the center of this discussion. And as the previous speaker was speaking, right best is the approach that we always need to take. And we also, this is why the communities are the center of everything. I'll be speaking to the subject, as you can see on your screens right now. And I also want to take this moment to acknowledge that we're not doing this work alone, but we as communities, we're working in consortiums, we're working together across the board to ensure that we have community voices adhered to or listened to. Next slide. I'll quickly be looking at when it comes to COVID-19, what are the key populations we are looking at? What are the vulnerable populations we are looking at? But also I'll be looking at what community-led response, data-driven and decision-making looks like, but also looking at the impact of COVID-19 on the communities, but also really share the successful strategies, the challenges and limitations. And in the same way, I'll be able to share some case studies to show that things really work when communities speak, but also I'll share some recommendations and then some conclusions. When we look at who key populations and vulnerable populations are in relation to COVID-19, we look at populations that are at high risk, exposure, but also who could be severely affected by the outcomes of COVID-19. And this could also include older adults, key populations, as we all know them, people living with HIV and other underlying medical conditions, but also people living in poverty. As you all remember, the lockdowns, what that did to communities. What is community-led monitoring, or CLM? Now, over time, we've had a chance to understand what CLM is, but also I just want to say it's a cycle of monitoring, but also coupled with advocacy, whereby communities are taking lead, and it's after they've been trained and are able and capable of taking on this process of gathering data, but also are able to analyze the data. But also I want to say that there's a UNAIDS defined a process, which is CLM is an accountable or accountability mechanism. It's a watchdog for health services. But also let's not confuse CLM with community-based HIV services. It's really important to note that. Quickly, as you can see on the screen, this is what CLM looks like. Communities themselves taking lead.
Richard, you have to prompt them to move the slides.
Oh,
yeah.
Okay, next slide. Yeah. So this is what it looks like when communities are taking lead. They are at the forefront and they are leading us. Next slide, please. So we have a process that CLM in action looks at data-driven responses. It's independent, it's community-led, and it's also that we do as communities. But also CLM data must be controlled and owned by communities. And over this entire time we've been here, data has been coming up. But I'm here to tell you that that data belongs to the community, and it's high time community own that data, not partners or anybody else. CLM must also include advocacy activities, but also must say that our community monitors must be service users who are trained to support and adequately be paid for their labor. As communities, for a very long time, we've done voluntary service. It's high time communities are paid for their service. Next slide, please. And also really continuing on this, we look at the cycle. It's a continuous data collection, but also it generates data that enables communities to ensure that they're working on targeted and effective community responses. So we're looking at facility level, national, and global level. Next slide. Now, on the screen, I just share some of the outcomes of what community-led monitoring can produce. And as you see, the People's Voice, Uganda, is one of the products that we produce annually that help us to understand or what we want in terms of PEPFAR programming in the country, but also it really shows the different reports, for example, left behind under lockdown, but also work on the mechanism of actually monitoring partners like PEPFAR and what they're doing in communities. Next slide, please. So this is also just another continuation of what we've been able to produce. Next slide, please. So let me dive into what community-led monitoring is, and I will also try to bring together what COVID-19 looked like, especially when we were in lockdown. Next slide, please. So during COVID-19 and subsequent outbreaks, and my fellow panelists also did allude to this, including Ebola, and also especially like in Uganda, for some reason, we're able to actually respond because of the lessons learned from HIV and also COVID-19, we're able to actually fight back Ebola in record time, which was really important for us. But also it's really important to look at how that also affected HIV, TB, and malaria, but also what it really caused. So here we're looking at disruption of essential services resulting from lockdowns. And I must say, as Uganda, we lived under the tightest lockdowns on the continent. This also disrupted the education system, but also the judicial system, and as I'll be sharing, what that also meant to the communities, but also the displacement of health systems interventions to now focus on COVID-19 and other pandemics or diseases were not prioritized. But we also experienced human rights violations, and what COVID-19 also showed us is that the vulnerable became more vulnerable. And it's something that we really need to take seriously, especially when we're dealing with pandemics, that we need to look at what that really looks like. The lack of access to medical countermeasures, particularly for people with HIV and health workers. And I'll be able also to share and what that really means in real sense. Next slide, please. Community trust in health systems is vital for effective response. CLM empowers communities to demand health systems accountability, but also build authentic trust in the health system through equal partnerships. CLM is essential when we come to response, but also using the data from the level of service user, CLM shines a light on what's actually happening and effectiveness of interventions. But also CLM gets vital community analysis to duty bearers in real time, because we are communities, we and the community, we know what's happening. So it's a very important mechanism to report back immediately. Next slide. Focusing on key and vulnerable essential populations and essential during COVID-19. Communities were at high risk and also exposure. Key and vulnerable populations experience greater barriers to access services due to stigma and discrimination. Many key populations do not have or did not have access to health services and social protection. In fact, there were some instances where key and vulnerable populations were looked at as the people who are easily carrying the disease, those sex workers, and that kind of stigma of populations is something that really also pushed communities into risk areas. COVID-19 disappropriately affected key and vulnerable populations, both directly and indirectly, by worsening their health outcomes, increasing their social and economic hardships, and also really pushing into inequalities and injustice they face. Our communities live from hand to mouth. But during the lockdowns, their businesses were closed, which meant their capital and everything that they owned was taken away. But also it meant pushing communities into spaces that were not safe for them. Looking at LGBT individuals who are being pushed into homes or families that had ejected them, but were enforcing the lockdown. Next slide, please. We saw increasing vulnerability to infection, but also severe illness and death due to underlying health conditions. We also saw disrupting access to essential HIV and testing services because lockdowns just happened and people are not allowed to move. People did not think, or governments did not think about someone who needed a refill of their art, or someone who needed their PrEP. But also, it exposed communities to human rights violations, such as arbitrary arrest, harassment, extortion, and abuse by law enforcement and others. Next slide, please. So I'll really look at how we address these challenges. One, we provided timely and accurate information on the vulnerability and accessibility and affordability and quality of COVID-19 prevention and testing, but also looking at the measures or the level of satisfaction and dissatisfaction. We also provided varying and evaluating the implementation and impact of COVID-19. And this really looked at programs and interventions, but also through documentation and reporting. Cases of human rights violations were able to put a light on things that were not going right, but also advocating for improved service delivery, policy change. This also really looked at ensuring that we have resource mobilization and really helping to address specific needs of the communities. Next slide. Now, I want to just hint that CLM is a collective, and we've been doing this across different countries in South Africa, Uganda, Malawi, Kenya, and this has expanded to look at what is really affecting services. Looking at the example of South Africa, COVID-19 focused data collection targeting communities most at risk really helped duty bearers to really understand and really work on rapid response rolling out. In Uganda, monitors were able to track firsthand human rights violations, and through this, corrective action did happen. But also drawing on the data of CLM programming and experiences of service users, advocates in Kenya, Malawi, Tanzania, Uganda, and Zimbabwe demanded strongly COVID-19 mitigation processes to be put in place. Next slide.
We have a minute more. Just a minute. Thank you.
Thank you. I want to share that because of the communities using the data and being at the front of everything, we're able to write in Uganda an open letter to the president. Expectant mothers were being affected and were not considered, but also that SRHR and SRHR services were not considered. And through this, the president was able to really open up the space to ensure that communities, expectant mothers did not require letters, seek services. But if we could go questions and conclusions on the slide.
In a minute.
And I will not read or say anything, but I'll use that time for all of us to really reflect and think about what this means and what we have really come up. Next slide, also to just show what success looks like and the strategies. And then the slide of challenges and limitations, please. Thank you so much.
Thank you very much. I want to thank the three speakers for a brilliant session. And we started by listening to Linda, who told us that clinical trials are important for multiple reasons, including the need to address the heavy burden of infectious diseases on the continent, including HIV. And this means that addressing these challenges, we have to face what it takes to build up the infrastructure and expand infrastructure beyond South Africa. And that South Africa, because of the trial sites that were in place, could promptly respond to the pandemic. And we saw the success case of South Africa continent with respect to COVID research and also the HIV research. We did also to Joy, who told us with clear figures, figure demonstrating that no dimension of preparedness had been met anywhere. And these dimensions include equity, leadership and accountability, as well as coherence of the global system. If you do want to read more, please know that there's the GPMT 2023 report on the fragile state of the response that is accessible on the GPMT website. She did emphasize the need to strengthen independent monitoring, and hereby I plug the issue that Richard raised about independent monitoring, including the community-led monitoring system, that the community can objectively also engage in monitoring. But what we're asking for is that those objective measures that comes from the community be plugged in into the national data response. And that this tool, as Richard clearly showed, can also expand to address epidemic, as it has successfully done, because it enabled them to objectively acquire data that could otherwise inform national response. I think as we move forward, we also should recognize, at least that monitoring should be built on accountability, and it's on accountability that we build trust rather than the other way around. Many times we push trust first, but I think what CLM does, or our monitoring tools, as we've heard, is that accountability comes first, and thereafter we can build trust. I think our facilitator also has one point to note, and thereafter, please wait as we call the winners of abstracts for track C and D to come up, and we'll give them their awards. Thank you very much. Over to you.
No, I think just to give some continental spin on today's. First, our panelists did a great job, justice to the topic. I think those that you see there have been at the front lines of the COVID-19 response. I think it's really great what Glenda and the team have done to Africa. It was just for South Africa, but Africa on its rest. We were involved in several continental surveys where Prof. Morenike actually developed some of the tools for the African Union. I think the community and the response around PPI is extremely important. Clearly, we are not ready for any future pandemic. We need to work on, we need to invest into research and development, science and innovation to be able to drive response to future pandemic and financing as well. Thank you so much, Professor Morenike.
On that note, I would like to, with pride, invite Professor Mike Chirenchi, who will be presenting the Traxia Award to Mr. Wayne Ochain Otino from Kenya. Please, let's show appreciation. Thank you. And please, once you do the presentation, just sit down briefly, and then we'll present the second. Excellent. All right. Second person. Thank you. Please just sit down briefly. We'll invite the
Good morning to you all. Firstly, I really want to thank, I think that is an oversight, but I really want to thank the scientific committee who scored the abstracts. As you can see, they didn't only score the abstracts, they also worked on this plenary. Selection of plenary is not an easy thing for a scientific conference. So I want to recognize, if there are members of the scientific committee, can you please stand up? Because we must thank you. Nyarazo and team and everybody, please stand up, because Professor Shakaniko and all of you, I think you need to be recognized. It is important. It is a marathon task to come up with a scientific, so you can sit down. So the second thing, I think yesterday, it was not mentioned, at least in English, that the committee, ICASA did a selection of best scored abstracts. So those people in Zimbabwe, you saw the lady from Blawayo, those were best scored abstracts. So I just wanted to mention that that's the background of this selection. And thank you to Luc Baudin, who really worked out for this. There's a monetary value for the best abstracts. So I just want to say that Wayne Ocheng Otieno from Kenya, the title of his abstract was Amplifying Voices Enhancing Beneficiary Experience via Virtual Anonymous Feedback for Adolescents and Young People's Program in Siaya County, Kenya. So it was scored, and it's a very good abstract. So congrats to you,
the second one here.
Wayne. Thank you.
Thank you very much, Mike. So I'll be calling on Dr. Safia Toutiem, who's the former Minister of Health of Senegal and the chair of the ICASA 2023 Leadership Program Committee, to present the award for the winner of Track D in the name of Miss Princess Rudo Mahiri from Zimbabwe, with the abstract titled Beyond Metrics, how the simple participatory assessment of real change tools provide a holistic approach to advocacy measurement. Thank you. She's coming, yeah. Thank you. Congrats. Thank you very much. So just to encourage us to keep submitting, this abstract winners also comes with a $1,000 award, and also encouraging every recipient, as well as abstract, yes, and presenters that SAR is going to launch his journal in the coming year, and please be willing to submit your manuscript to the journal. On that note, I want to thank everybody for participating, and asking all the presenters and abstract winners to please, as well as the SAR board, steering committee, to please just stand forward and we'll take a picture. Otherwise, I wish everyone a wonderful day and continue to enjoy the conference. Thanks for being here.
Please leave the microphones, the headsets by the door. Don't forget to collect your tags. Please collect your tags by the door as you leave the headsets. Collect your tags by the door as you leave the headsets.